Yes, yes, sir.
Perfect. Thank you so much. Thank you again. Wonderful session that you have and wonderful meeting. And I enjoyed listening to all the stalwarts of echocardiography in Bangladesh. This is truly inspiring to see the work and effort that is being done in Bangladesh. So thank you so much for the kind invitation. So my job is to talk to you about the role of echocardiography in the ICU in the COVID era. I have no relevant disclosures. And first of all, I'd like to say, to recognize the people who have fallen to COVID-19 and salute the heroes who are working in the front lines every day. So my thanks to all of those who are working in the front lines all over the world, especially those who are taking care of COVID and those who are using echocardiography and whatever they can to help people. So the learning objectives for this particular talk are to review the impact of COVID-19 on critical care services, describe the value of echo in critical care, and to discuss the risk mitigation strategies. So as an outline, I'll talk about the impact of COVID, what it has had on ICU care, what the cardiovascular burden is, the value of echo in the different stages of COVID-19, the different strategies we can use, including prevention, and point-of-care ultrasound and artificial intelligence, followed by a summary at the end. So let's start by discussing what the impact of COVID has been. And it is no surprise that if you look at the timeline from the beginning, this is now old news, how much the death toll is climbing. Just in the very, very few months, we have seen the world impacted by this tremendously ever since December of last year, when the first patient developed symptoms of the coronavirus in Wuhan, to the identification of the virus of COVID-19 on January 7th, up to the first case outside of China on January 13th. And then you can see how rapidly things have escalated all around the globe. And every day, every number becomes an outdated statistic, which is really sad, including this one, where I took this one last month, and it just doesn't make sense anymore because the numbers have skyrocketed even beyond that. The scale of this pandemic is something that none of us have ever seen in our lifetimes and are unlikely to see for generations to come. Hopefully, this is just a once in a generation or once in a century kind of event, and hopefully it never happens again. But if you look at the cumulative new cases around the globe, it is just this graph just gives you a different story completely. And just today, which is actually November 13th in Bangladesh, but it's still November 12th here in the United States, this is the COVID-19 dashboard at Johns Hopkins University, where you have 52 million cases globally with 1.29 million deaths. This is 1.291837 deaths too many. And it shouldn't be that way, with 242 deaths just in the United States alone. But then again, Bangladesh isn't spared either, with 427,198 deaths so far. Cases so far, and 6,140 deaths. This is no small matter for any country in the world to bear, this sort of pandemic and the devastation it has caused. So needless to say that we all have a role to play. We all have a very important role to play. And as was mentioned just before me, this is a global community. What happens in one place does not stay in one place. It travels around the world. We are all interconnected as a community, and we all should learn from each other. So let's think about the impact of COVID on two things. One is the provision of critical care services, and the other is the cardiovascular burden that is imposed by this virus. So first, when we think about the provision of critical care services, the impact is that you have fewer non-COVID beds available. So the regular care is also impacted. You also have to create separate units. This is a drain on the infrastructure. There's a strain on personal protective equipment that you have to have for carrying all of these cases and all the suspected COVID cases as well. And as cases rise, the strain on PPE supplies becomes a problem. Now, none of us had used the word or the letters PPE before this very much, but now it's become like everyday use. This strain on staff, now that's the mental health strain. We all are going to suffer from the consequences of not being able to do what we do to relieve our stress while taking care of COVID-19 patients in the ICU or in the clinic or anywhere else. And this put a strain not only on our mental health, on our physical health, but on our financial health as well throughout the countries. And a lot of us cannot afford to do that anymore. What about the disease burden? I'll talk briefly about the cardiovascular effects, but then, of course, there are cerebral effects. This is a systemic disease. There are pulmonary effects. There's acute kidney injury. There are microvascular thrombosis. There's hypercoagulability and disseminated intravascular coagulation. And there's vomiting and diarrhea. So you can see the systemic impact that COVID has throughout the body, not just the heart. And then when you think about the cardiovascular burden, that is somewhere where we all come in as cardiovascular specialists, armed with the tools that we have to help people with cardiovascular disease. Now, when we think about the cardiovascular burden, there are factors which decrease the oxygen supply to the body, which include pneumonia, ARDS, hypotension, and bradycardia, and all of these initiated by the cytokine storm will serve to decrease the oxygen supply. And then you have inflammation, including that cytokine storm and release of pro-inflammatory mediators. And then you have microvascular complications such as thrombosis and endothelial dysfunction. And all of these serve to increase or enhance that cardiovascular burden that we all see in COVID-19 cases. If you haven't seen it already, you're likely to do so very soon. So what about echocardiography in COVID? And you'll hear about this in the course of the day and the sessions to come. But in the ICU, you will see frequently a lot of cardiovascular manifestations of COVID. Even if you're not a primary critical care person, you will be called to look after patients with cardiovascular disease, and that may include right ventricular dysfunction, myocardial injury or heart failure with reduced ejection fraction, cardiogenic shock, which is where critical care folks will come in to take care of these patients. Cardiac tamponade is also an infrequent complication. Pericardial effusion is seen very often. Stress cardiomyopathy, STEMIs, or even heart failure with preserved ejection fraction. These are all the spectrum of cardiovascular diseases or manifestations of COVID-19 that you can see, where echocardiography becomes crucial in handling the diagnosis and is very suitably equipped to give information in real time very quickly to clinicians taking care of these patients. So it is an invaluable tool to look after patients with COVID-19 in the unit and beyond. So whether it's early in the disease with impending shock or just to establish a baseline for patients, or during the COVID crisis, when you have shock, you can have tamponade, you can have valvular involvement or ongoing myocardial injury, to even after patients leave the ICU with sequelae of myocarditis, chronic disease, decrease in function, valvular deterioration, or even look at function after intervention. In all these three areas, echo becomes a critical tool to evaluate and take care of patients with cardiovascular disease in the COVID pandemic, not only before, but during and even after. So that includes the critical care services. So what should be our strategy in echo services? All of us know how to do echocardiography, but how do we manipulate or adjust our echocardiography services to match the burden of the pandemic? Now, very early on in the pandemic, I had organized a group at the American Society of Echo to release a statement. These were a group of experts that had coalesced. I'm by no means an expert. I just have some experience, and I was sharing my experience. But I pulled together this group of very fine people, and we constructed a statement. Now, remember, this was in record time. We did this within 5 days. We released a statement for guiding echo services throughout the world. And the reason why we did that was because people didn't know what to do. This was March 18th. This was very early on in the pandemic, and people didn't know what to do. I was getting emails and messages throughout very quickly saying, what do we do? How do we organize our echo services? We don't know what to do. And so this is what we did. We got together a group of people and released a statement, and we focused on who we need to do an echo on, where we need to do the echo, and how we need to do the echocardiograms. So in terms of who we need to do the echo on, and we need to use appropriate use criteria. This is very useful. We should do it only when there is a clinical benefit that is likely. When there is a management decision that may be pending, such as use of inotropes or mechanical circulatory assist devices. We made special provisions for TEE, stress echocardiography, pediatric echo, and intraoperative echo. All these required special statements that were released by subspecialty members. The important thing was to triage people who come with cardiovascular disease and test positive for COVID-19. The other question was, where do we do this? And so the goals of this are to have minimal impact on non-COVID cases, because we still have a service to run with non-COVID patients. We need to protect our echocardiographers first and foremost, in addition to protecting our patients. We need to make sure that the equipment is reusable. And when we think about equipment, some of the considerations are whether to have a dedicated room versus portable equipment, whether to have dedicated equipment itself. And what about the PPE usage, and how do we ration that in a situation where we have a resource constraint and we don't have enough PPE supplies, and how do we monitor that? Then the next thing was how to do it and what our approach should be in terms of what to do with an echocardiogram and what to do when patients come in for echocardiography, how do we do it? And so the way we did that was to create this algorithm, which we released, and you can still find it on the ASE website, and it stratifies people according to the COVID status and tells you exactly how to go about doing echocardiograms with airborne precautions or droplet isolations or contact precautions, and what special precautions you might need to have. The other thing was that we talked about the POCUS protocol, or the point-of-care ultrasound, and what value point-of-care ultrasound has within the COVID pandemic, how to do an abbreviated exam, how to focus on exactly the findings that you want, and how to get exactly the information that you are looking for in patients with myocardial manifestations of COVID-19. And so this outlines really well what we need to focus on. And there's an algorithm that we developed regarding COVID-19, which is suspected, how to do the initial evaluation, how to do the point-of-care ultrasound, whether it is sufficient or not sufficient, and what to do after that. Now, this is an example of the use of artificial intelligence or in point-of-care ultrasound, where you have devices such as this, and I use this with permission, where it guides even the novice practitioner. So even if you have people or critical care intensivists or nurse practitioners or even paramedics who want to use this device, it will help these practitioners find the right views, even if they haven't done an echo ever before. And it will guide them to the views and will provide them with information regarding ejection fraction, regarding progress of information, and it will even tell your service, your echo lab, as to who has done what and how well they've done it. So it's a great tool that's emerging using artificial intelligence for echocardiography images. This is another example of a software as a service model from a UK company called Ultramics. Again, I don't have anything to do with them, but I was really impressed by what they have. And they can use any image acquired from any vendor, whether it's Philips or GE or Siemens or whatever it is, and they feed it into the system, which gives you automated EF and automated parameters that are really, really helpful for even the novice practitioner, and even to track long-term usage. And it synchronizes perfectly with whatever systems that you might have. So there is a definite role for artificial intelligence in the care in echocardiography as you use it to care for patients with cardiovascular disease. A brief word about intraoperative echo as well. When we try to talk about this in critically ill patients, we focus on what is the aerosolization risk and what is the contamination risk. And when we think about the aerosolization risk, we think about non-intubated versus intubated patients. And in non-intubated patients, there's a high risk of cough. There's no option for source control. And the operator is by definition close proximity. You're very close to the patient. There's no chance of social distancing. In intubated patients, they are mechanically ventilated. There's risk of aerosolization with endotracheal tube intubation and extubation and airway manipulation. And again, the operator is in close proximity. But then what is the contamination risk? There are increased secretion risks from upper airway and the oropharynx, and the frequent contact with contaminated secretions. These have multiplicative effects on other surfaces as well. So there's lots of contamination risk going around. Now, a brief word about a clean room and a less clean room. Now, whenever you have two rooms that are separated by airflow, so there's a high area of high pressure which flows to an area of low pressure. And the operating room that we have designed are designed to be positive pressure rooms which feed into or blow air into an induction room or a hallway, which is the less clean room. So it keeps the operating room clean. On the other hand, an airborne isolation room in the ICU is a negative pressure room where you have a hallway which has clean air coming into the less clean area. The entire idea in both these situations is to avoid contamination of a clean area. The special problem becomes when you have a contaminated patient in a clean area, such as the operating room, and there you have to take very, very special precautions. So what are the principles that we follow? We need to assess the indication for TEE, defer or cancel TEE if it's unlikely to change management, and consider alternatives or less risky imaging modalities if available. So first, we think, is there in an emergent cardiovascular surgery case is posted, is a perioperative TE essential or indicated? If it's yes, we proceed with it with adequate PPE precautions. If it's not indicated, we consider repeat TTE before the start of the procedure to confirm LV and RV function. And then if there's unexplained hemodynamic instability, we proceed with the TE in the operating room. So what do we consider essential? So some of the essential indications are myocardial infarction with mechanical complications such as papillary muscle rupture, type A aortic dissection, infective endocarditis with valvular involvement, initiation of mechanical circulatory support, prosthetic valve assessment, and hemodynamic instability with suspected complications. What about living with COVID-19? And this is not going away anytime soon. So our critical care services are going to be bent, and a lot of strain will be put on them when we live with COVID-19 throughout the world. And this is not going to go away. So the idea is to have a four-pronged strategy where we screen for all patients for COVID, we defer the COVID positive cases, we build capacity, and we plan for a long duration of this problem. We also need to sanitize facilities and sanitize equipment and ensure that PPE is available for all practitioners and ensure social distancing wherever we practice this. And this may become the new norm for a long, long time to come. I'm hoping it isn't, but I'm guessing that it will. We also have a plan for inpatients. We have to have portable equipment, especially for critical care units. Dedicated COVID areas have to be thought of. We need primarily to protect not only our patients, but also our staff who are taking care of them. These are frontline workers, and they need to be protected. We also need to follow guidelines such as local trends and local health authorities when they tell you what's going on. And we may need to flex up or down on our services. We may need to relax our restrictions when the phase of the pandemic is lower, and we need to flex up and increase our services when the pandemic phase is fully raging on. So these are some of the four-pronged strategies and principles that we may have to follow living with COVID for the conceivable future for now. Whatever kind of service that we have in terms of echocardiography, wherever we are in the world, we will need a long-term strategy for this, and a short-term strategy is not going to work. So I'd like to end with some key points. I want to end on time. So in summary, echo is an essential imaging modality in critical care COVID cases, as we just talked about. Innovative technology is essential, and it may become very useful to protect from COVID while preserving the quality of echocardiography, and artificial intelligence might come in very handy. And remember, these devices come at a fraction of the cost of some of the bigger echo machines that you have, and they preserve portability as well. And again, we may need to follow strict standard sanitation protocols to protect patients and staff. That is absolutely essential, and that may happen for a long time because we need to develop plans finally to live with COVID. I want to thank you all for your kind attention. Thank you for the invitation to speak at the Bangladesh Society of Echo virtual meeting, and I'm really happy to be here. Thank you for your attention.